بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. I'm Nazik Elmalaika Husain, a professor of pathology at the Faculty of Medicine in Durman Islamic University, Sudan. It's of my pleasure to welcome you. And in this recording, we are going to discuss only two entities of the diseases of the endometrium, which are many. We will discuss first endometriosis and know the basic theories behind it, and an example of the tumors of the endometrium and the meiometrium. We are going to give an overview about leiomyomas as an example of benign lesions or tumors, and the endometrial carcinoma. Starting with the diseases of the endometrium, endometriosis is characterized by endometrial glands and stroma in a location outside endometrium. The presence of endometrial glands and stroma in a location outside the endometrium. It is different from adenomyosis, which is the presence of endometrial glands higher up within the myometrium. Endometriosis occurs in as many as 10% of women in their reproductive years, and in nearly half of women with infertility. Therefore, it is important that this justifies its discussion here. Endometriosis is a common cause of dysmenorrhea and pelvic pain, irregular menstrual cycle and pelvic pain, and may present as a pelvic mass filled with degenerating blood, occasionally called chocolate cyst, and sometimes mimics abnormal lesions or neoplastic lesions in the ultrasonography. Endometriosis is frequently multifocal and may involve tissue in the pelvis. These tissues may be the ovaries, the pouch of Douglas, the uterine ligaments, the fallopian tubes, and rectovaginal septum. Less frequently, it may involve more remote sites of the peritoneal cavity and about the umbilicus, and uncommonly lymph nodes and lungs, and even heart, skeletal muscles, and bone. There are three possibilities or theories behind endometriosis that have been invoked to explain the origin of these dispersed lesions. They are abnormal lesions. They are glands and stroma, endometrial glands and stroma, in very odd locations. The first theory is the regurgitation theory, which proposes that menstrual backflow through the fallopian tubes. This is why it is regurgitation, the menstrual backflow through the fallopian tubes with subsequent implementation. Indeed, menstrual endometrium is viable and survives when injected into the anterior abdominal wall. However, this theory cannot explain lesions in the lymph nodes, skeletal muscles, or lungs. Therefore, scientists looked after another theory, which is called metaplastic theory, that possesses or proposes that the endometrial differentiation of the chyliomic or celiomic epithelium occurs, and it is the origin of the endometrium itself. The chyliomic epithelium is the origin of the endometrium and the ovarian in lining and others, okay, and even the cervical, the endocervical lining. Therefore, there is a possibility of metaplastic differentiation. This theory, too, cannot explain endometriotic lesions in the lungs and lymph nodes. And thirdly came the vascular or lymphatic dissemination theory that has been invoked to explain extrapelvic or intranodal implants. This image shows the three theories, which is the regurgitation theory, that the endometrial cyclic blood backflow through the fallopian tubes and implement or get implanted in other sites, which may be the ovary, the endometrial wall, and others. The second theory is the metaplastic differentiation, the differentiation of the chyliomic epithelium in other abdominal sites. And lastly, the extrapelvic dissemination through pelvic veins in that may occur through veins or lymphatics to disseminate to lungs and lymph nodes. These are the three theories that have been invoked to explain the abnormal implantation of endometrial stroma and glands in odd sites outside the endometrium. The clinical manifestations of endometriosis depend on the distribution of the lesions. So, extensive scarring of the oviduct and ovaries, if the endometriosis occurs in ovaries, often produces discomfort in the lower abdominal quadrants and eventually causes sterility or infertility, because therefore it is a common cause of infertility. Most infertile women discovered to have endometriosis. Then amplification reflects rectal wall involvement, and dysuria reflects involvement of the uterine and bladder cirrhosis, respectively. In almost all cases, there is severe dysmenorrhea and pelvic pain as a result of intrapelvic bleeding and periuterine adhesions. Secondly, we come to the tumors of the endometrium. We start with the benign tumors. An example is leiomyoma. Benign tumors that arise from the smooth muscle cells in the myometrium are properly termed leiomyomas. However, because they are firm, they are more often referred to as fibroids. They are the most common benign tumors in the females and are found in 30 to 50% of women during reproductive life. Some genetic influence may be involved, and these tumors are considerably more frequent in blacks than in whites. They are very common in Sudanese women. Steroids and possibly oral contraceptives stimulate their growth. Conversely, they shrink postmenopausally. Macroscopically, leiomyomas are typically sharply circumscribed. We will see a photo in a minute. They are firm, gray-white masses with a characteristic whorled cut surface, whirling, rounded like the onion skin. This is macroscopic. This is a macroscopic appearance, characteristic macroscopic appearance of the leiomyoma or fibroids. Well circumscribed, firm, white to gray, with a whirling pattern. This pattern will be seen here microscopically. This is the whirling or whirled pattern. They are composed of smooth muscles and interlacing fascicles of fibroblasts. Okay, this is the lower, this is a diaphragmatic representation, and this is a low power view, and this is the higher power view. Interlacing bundles. Therefore, some of the cells appear rounded and others appear elongated. They may occur singly, but most often multiple tumors are scattered within the uterus, ranging in size from small seedings to massive neoplasms. They are commonly multiple. You can find up to 20 leiomyomas in the uterus in different sites of the uterus. Some leiomyomas are embedded within the myometrium, and they are called intramural. Others may lie directly beneath the endometrium and are called submucosal, or directly beneath the serosa and called subserosal. The latter, the subserosal, may develop attenuated stalks and even become attached to surrounding organs, from which they develop a blood supply and then free themselves from the uterus to become parasitic leiomyomas. They can be solely separate from the myometrium and called parasitic leiomyomas. Larger neoplasms may develop foci of ischemic necrosis. Within the center, there is necrosis because they lost the blood supply, with areas of hemorrhage and cystic softening, and often menopause. And after menopause, they may become densely collagenous, very hard, full of collagen, and even calcified with calcium deposition. Histologically, the tumors are characterized by whirling bundles of smooth muscles, as we have seen before, duplicating the histology of the normal myometrium. Leiomyomas of the uterus may be entirely asymptomatic and be discovered only on routine pelvic or post-mortem examination. Very common. The most frequent manifestation when present is menorrhagia, excessive menstrual bleeding. Large masses in the pelvic region may become palpable to the woman or may produce a dragging sensation. They may become very large up to or mimics a full-term baby. Benign leiomyomas rarely transform into sarcomas, and the presence of multiple lesions does not increase the risk of harboring a malignancy. Leiomyosarcoma is the malignant form of the smooth muscle cells. The benign one is leiomyoma, and the malignant one of the smooth muscle cells is leiomyosarcoma, and we are not going to discuss it here, but this photo shows how it is different from the leiomyoma. There are multiple bizarre, abnormal, irregular, large cells with large nuclei and mitotic figures. Other tumors of the endometrium we will discuss is the endometrial carcinoma because it is common. Endometrial cancer appears most frequently between the ages of 55 and 65 years and is distinctly uncommon in women younger than 40 years of age. There are two clinical settings in which endometrial carcinoma arise: in perimenopausal women with estrogen excess, and in older women with endometrial atrophy. Two clinical settings: perimenopausal with estrogen excess, and in older women with endometrial atrophy. These scenarios are correlated with differences in histology. The endometrioid and serous carcinoma of the endometrium, respectively. The endometrioid is common in the perimenopausal women, and the serous carcinoma is common in the elderly postmenopausal women with endometrial atrophy. Well-defined risks or risk factors for endometrioid carcinoma, in which there is an excess of estrogens, are obesity, which increased synthesis of estrogens in fat deposits is a main factor that enhance endometrioid carcinoma development, diabetes, hypertension, and infertility. Women tend to be nulliparous, often with non-ovulatory cycles. These risk factors point to increased estrogen stimulation. In endometrioid carcinoma, there is increased estrogen stimulation, and indeed it is well recognized that prolonged estrogen replacement therapy, common in CA breast or some carcinomas, and estrogen secreting ovarian tumors, increase the risk of this form of cancer. These tumors are termed endometrioid because of their similarity to normal endometrial glands. This is macroscopically a uterus full of abnormal endometrial glands. This is the uterus open into two halves, and this is microscopic picture of, this is the low view and this is the high power view. Endometrial glands, these are well differentiated, multiple proliferating endometrial glands. Some are back to back. This is endometrial serous carcinoma with pouch or lakes of mucin and increased mitotic activity even higher, not only beside the basement membrane. In conclusion, endometriosis, we discussed in this recording, is endometrial glands and stroma in a location outside the endometrium, and it has three theories: regurgitation theory, metaplastic theory, and a dissemination or neoplastic theory. Benign tumors that arise from the smooth muscle cells in the myometrium are termed leiomyomas, often fibroids, and the malignant ones are leiomyosarcomas. There are sarcomas. Endometrial carcinomas include endometrioid, which is common in the perimenopausal area due to excess of estrogen, and serous carcinoma, which is in the postmenopausal women. Increased estrogen stimulation predisposes it. And thank you very much. Wassalamu alaikum wa rahmatullahi wa barakatuh.